General mechanism of cardiac muscle contraction. Cardiac muscle contraction occurs via excitation-contraction coupling, ECC, utilizing a mechanism called calcium-induced calcium release, CICR. ECC is the process of converting an electrical stimulus, AP, into a mechanism response, muscle contraction. SICR involves the conduction of Ca ions into the cardiomyocyte, leading to the further release of ions into the cytoplasm. Ca prolongs the period of cardiac muscle cell depolarization before repolarization begins. Contraction of cardiac muscle occurs due to the binding of the myosin head to ATP, which pulls actin filaments to the center of the sarcomere, the mechanical force of contraction. Cardiac muscle contraction initiation and execution occur in the following steps. An AP, induced by the pacemaker cells in the sinoatrial, SA, and atrioventricular, AB, nodes, is conducted to contractile cardiomyocytes through gap junctions. As the AP travels between sarcomeres, it activates the Ca channels in the T tubules, leading to an influx of Ca ions into the cardiomyocyte. Ca in the cytoplasm then binds to cardiac troponin C, which moves the troponin complex away from the actin binding site. Removal of the troponin complex frees actin, which becomes bound by myosin and initiates contraction. Intracellular Ca is then removed by the SR, dropping the concentration of intracellular Ca. This decrease in intracellular Ca concentration returns the troponin complex to its inhibiting position on the active site of actin. Ending contraction as the actin filaments return to their initial position, relaxing the muscle. General mechanism of smooth muscle contraction. The contraction of smooth muscle is not regulated by the binding of Ca to the troponin complex, as is seen in cardiac and skeletal muscle contraction. Smooth muscle instead utilizes commodulin, an intracellular second messenger which binds calcium. Smooth muscle contraction initiation and execution occur in the following steps. 1. Intracellular Ca concentration increases when calcium enters the cell and is released from the SR. 2. Calcium binds to commodulin. 3. Ca commodulin activates myosin light chain kinase, MLCK. 4. MLCK phosphorylates myosin head light chains and increases myosin ATPase activity. 5. Active myosin cross bridges slide along actin and create muscle tension. 6. Smooth muscle relaxation occurs as free Ca in the cytosol decreases when Ca is pumped out of the cell or back into the SR. 7. Ca unbinds from commodulin. 8. Myosin phosphatase removes phosphate from myosin, decreasing myosin ATPase activity and muscle tension. Pathophysiology. As muscles are found throughout the entire body, the pathologies associated with abnormal muscle contraction are extensive. Therefore, while this list delineates high-yield pathophysiological conditions related to muscle contraction, it is not exhaustive. Skeletal muscle contraction pathology. 1. Duchenne muscular dystrophy. 2. Becker muscular dystrophy. 3. Myotonic dystrophy. 4. Lambert-Eaton syndrome. 5. Myasthenia gravis. 6. Myositis. 7. Bell palsy. Smooth muscle contraction pathology. 1. Asthma. 2. Gastroparesis. 3. Nephrolithiasis. 4. Chronic kidney disease. 5. Neurogenic bladder. 6. Infertility. 7. Pulmonary hypertension. Cardiac muscle contraction pathology. Congestive heart failure. Cardiomyopathy, for example, dilated, hypertrophic, restrictive. Clinical significance. Muscle spasm. Muscle spasms, also known as muscle cramps, are involuntary, painful, and localized contractions of an entire muscle group, individual muscle, or select muscle fibers. Muscle spasms can last anywhere from a few seconds to a few weeks, depending on the muscle affected and the mechanism of the spasm. Manual muscle testing, MMT. As previously discussed, MMT is used as a clinical tool to assess muscle strength and is graded on a scale from 0 to 5. MMT is also used in rehabilitation and recovery practices to assess impairments and deficits in muscle performance, including strength, power, and endurance. Pharmacology. Clinically, it is essential to recognize that many medications today will affect muscle contraction at some level. Therefore, whether it be the main effect of the drug or a side effect, it is crucial to understand the uses and consequences of administering medications to patients. Pharmacological agents that directly affect muscle contraction include, but are not limited to, skeletal muscle relaxants. For example, botulinum toxin, cyclobenzaprine, methocarbamol. Vasodilating medications. For example, hydralazine, nitrates, milrinone. Volatile anesthetics or succinylcholine can lead to malignant hyperthermia.